Okay, so welcome to the Stroke Committee meeting of GTAC. I'd like to call this to order. I've done a virtual roll. Everyone's here with the exception of Salvador. Not here? Nope. And Daryl Pyle is excused for some family stuff. So I'd like to start with chair comments. And these are basically things that just come up that I thought would be worthwhile to discuss. And the first is there's no certifying agency, that is DNV, HVAP, Joint Committee, that is better than another or should be used in advertising as such. That is not consistent with our state designation. We can use multiple different certifying agencies, and it's not that one is better than another. And I don't think it's quite cricket for someone to say that one is better than another. It's also important to remind people that it's not okay to advertise as a stroke facility unless you're designated by the state, that's part of the rules that's in place. The next thing, item that came up, if you're not meeting the requirements for your designation level, you're required to contact your EMS provider, the RAC, referring hospitals, and the Department of State Health Services. Examples would be if you have no CT techs or you surreptitiously bring in CT techs for a certification process and then don't have them. You know, basically we're trying to help people, and so if you're not providing the services that you say you are, that's not fair to the patients that might be coming in on EMS services. You're required to report that to the DSHS within 5 days. So just a reminder, if you need to go on divert, there's nothing wrong with that, but you need to tell people that you're going on divert. Next up, currently, TTAF, Joint Commission, are the only certifying bodies for support stroke facilities, level 3 facilities. And so when you're doing transport plans, you need to take that into consideration. Also in regards to advertising, whether you're a stroke facility in the state. Okay. At the last meeting, I brought up what are the duties for GTAC. On this meeting, I wanted to bring up from Senate Bill 330 back in 2005 what the duties of the Stroke Committee is. And per our legislative mandate, we're required to help with stroke emergency transport planning, that is training requirements on stroke recognition and treatment, including emergency screening procedures, a list of appropriate early treatments to stabilize patients, protocols for rapid transport to stroke facilities when rapid transport is appropriate and it is safe to bypass another healthcare facility, plans for coordination with statewide agencies or committees on programs for stroke prevention and community education regarding stroke and stroke emergency transport, in developing stroke emergency transport plan and stroke facility criteria. The Stroke Committee shall consult criteria for stroke facilities established by national medical organizations. And regarding to the rules, the Executive Commissioner may adopt rules regarding a statewide stroke emergency transport plan and stroke facility criteria based on the recommendations of the Advisory Council. So we make recommendations and they may or may not be accepted, but that's what we're supposed to be doing. sorry for all my coughs. I want to give a report or update on the Texas Council of Cardiovascular Disease and Stroke in regards to multiple things, but the Regional Advisory Council Stroke data collection. The council is going to have a meeting here, 1 o'clock on Friday, and I want to invite everybody to come to that, especially members of the RACs. I want to thank the Department of State Health Services for their combining elements for data collection. What they did was they had recommendations from this committee, they had recommendations from the Cardiac Care Committee, they had American Heart Association recommendations, they had different RACs recommendations, and they put these all together. The last data collection set that we did was primarily EMS based, but because NMSIS is going to replace that and we'll have elements from the NMSIS data collection system, this year is more focused on the hospitals. And if you remember, to be a designated stroke center, you're supposed to participate within a registry. And so this would meet that. And so they've worked very hard to come up with elements that are not onerous for the RACs, that people could use different collection tools, that is, collection tools that individual RACs have already used, or get with the guidelines or others, and I think they've done a really great job, and I want to thank them for that. Well, we can go over that more at the council meeting on Friday. The second thing, I guess, is that the data that's going to be collected will be shared with the Cardiac Care Committee, this committee, the RACs, and ultimately GTAC. The money that's going to the RACs, they can use that money to contract for help to do that, or they can associate with other RACs if they want to do that as well. The other thing that the council is doing is they have a chronic care subcommittee that's looking at strokes after the fact, and they're going to be having a working conference on that coming up. The other thing that the council will be doing on Friday afternoon is Dr. Darren Zaranek will be speaking on an update on stroke and Hispanics, a report on the brain attack surveillance in Corpus Christi that's basic, and basically going over the Hispanic paradox. I find it very interesting that people in other states are studying our state, but that's what's going on, and this is a really, really great presentation. So that's my update. Does anyone on the dais have questions about the TCCVDS? Nope. Okay. So next on our agenda is Stroke Committee Work Group assignments. But part and parcel of that, I thought it would be nice if everyone introduced themselves and told a little bit about themselves. And if that's possible, to give me a break from coughing. We can start with Paul and then just go around the dais.
Hi, my name is Dr. Paul Hansen. I'm a stroke neurologist and neurointerventionist up in the Dallas area. I've been part of the GTAC for about a year now, so we're getting close to it. I'm happy to be here and happy to help out.
Okay, my name is Sarah Hancock. I'm the stroke coordinator at University Medical Center in Lubbock, and this is actually my first GTAC meeting, so I'm excited to be here.
George Cravens, neurosurgery, Fort Worth, Texas, primarily in microvascular neurosurgery. I've been on the committee, I guess, 2 cycles now.
Deb Moats, Regional Stroke Coordinator for Baptist Health System in San Antonio, and this is my 2nd cycle as well on this committee.
H.T. Fillingham. I'm EMS Director for Fisher County Hospital District EMS in Rotan, which is actually very rural and frontier.
Hi, I'm Lisa Hutchison. I'm a stroke coordinator at East Texas Medical Center in Tyler, Texas. I'm also the chair of the acute care division for TTAF, and this is my second cycle on this committee also.
And I'm Neil Rutledge. I'm a neurointerventionalist and not talking well at the moment, so I'll pass it on to Dr. Morton.
I'm Joanna Morton. I'm a vascular neurologist based here in Austin. I co-chair of our CAT RAC here. This is my first cycle, second go-around, I guess.
I am Holly Barnes. I'm the stroke coordinator at Baylor Scott and Watt Hillcrest in Waco, and this is my first GTAC meeting. Well, on the committee. Sorry.
Cool. So what I'm going to do is we've had several active work groups, but what I'm going to do is add another work group and assign everyone to a work group so that everyone can help shoulder the work. The three work groups, we already have an education and training work group. We have transport work group, and the new one's going to be a data committee work group. For the data committee work group, I'd like to initially start with Dr. Morton being the head of that. And for that, we'll put Salvador Flores on that, Lisa Hutchinson on that, Joanne Morton. And then in regards to the transport work group, Dr. Cravens has been heading that, but we'll also put on that Paul Hansen, Daryl Pyle, and Holly Barnes. And then in regards to the education work group, we'll have Homer Fillingham, we'll have Deborah Motz, and Sarah Hancock. Did I cover everybody? Okay. So what are these work groups going to do? Well, the education, I mean, we've been working on a lot of these a bit. The education and training work group, basically we've been working on first responders, EMS providers with stroke scales, transport plan education, and helping work with the medical directors and the education committee on those. So they're appropriate liaison committees that we work with. On the transport protocols, we've been working on written recommendations out to 8 hours. We have a bypass plan that we've talked about for no more than 15 minutes, but there are other ways that that can be done. And then also, in regards to transport plans, it's important that the transport is fairly divided among people within the RAC. You wouldn't want to do something that wasn't fair to all the players. The data committee, which is new, we're going to have lots of data hopefully later in the year to review and analyze. And also that committee can recommend new elements for the next go-around that we can do. And in the meantime, we have several groups requesting to be certifying agencies for stroke groups, and I'm hoping that they can fill in with that for the short term. So enough talking for me right now. Next up is report from the stroke education work group. Mr. Philip, if you can tell us what updates, and actually if you can review what we've done and then where we're going, I think that would be great.
Okay, we initially set out to try to get some stroke-specific CEs available for EMS, and actually to have that included as part of our recertification process. And those have been added. We are continuing to kind of reevaluate what else we might need to do to see that is implemented, and that it's effective, and that it's getting the help out to the EMS guys, especially out in the rural and frontier areas that don't have a lot of call volume. I think that's basically kind of where we're at.
And we can also, put those on our website. We can vote to move forward to the general council and put that stuff on the website and develop resources for the medical directors and the education committee. So there's a lot of good stuff that we can do.
Yeah, we're looking at trying to get the resources thing. It's a little bit more than thought, but we'll get it.
Yeah. And he's done a lot of work. I mean, it sounds like it's not very difficult, but it's very difficult to do this when it actually comes down to putting the rubber on the road. So next work group report that may be a little bit longer. I was hoping Dr. Cravens, we haven't had a chance to hear. His work group has done a wonderful white paper on different things that can be done in regards to transport plans for the different racks. And I was hoping that you would get a chance to sort of tell everyone about that and then take questions.
Initially, we were asked to look at this and make recommendations regarding transport to either support stroke centers or primary or comprehensive, and the issue of the different RAC regions around the state and issues that arise because of the variability that's there, rural, urban, et cetera. In the last year, the International Stroke Conference, sort of the groundbreaking information, was not just relative to TPA and timing of treatment of that, but also the interventionalists doing clot removal, and the window for that being moved out to 8 hours. And obviously, to try to make a single, simple, straightforward recommendation for the entire state for all of the different RAC systems is a little bit, well, formidable, but probably impossible. But what's not impossible is to say, whatever the particular area or whatever RAC system, whatever those local rules and agreed to transfer criteria are, at the end of the day, the most important thing is this. You get to a center, a CT scan shows a large vessel occlusion, that patient is a candidate for clot removal, period, the end, up to 8 hours. And there's no place in the state we can't get somebody to a place where they can get that done. So whether you're in Lubbock or you're in Houston, the local politics, this kind of takes that away in the sense of if you have that particular criteria of the stroke disease process, then those patients, those candidates can be shipped to a place where that's done. Now, to select who, where, and what arrangements are made, I think that becomes a regional or a RAC-centric decision. And so we didn't want to make some specific recommendation that's, may fit well for an urban setting or may fit well for a rural setting, but obviously Houston, Dallas, San Antonio, Austin are all very different, just in the sense of how those stroke centers and hospitals, work together. So it was a very generic recommendation, but it incorporates the standards that are both national as well as international. And I think in that sense, how we then decide, or the EMS systems decide to work out the local issues, that can be left there. But overall, the main goal of this was to incorporate something that says this is the standard that we're going to follow, and that's something we can all do. And so I have a hard time imagining that there's a region that can't agree to say this is the appropriate thing to do for these patients, and we can't get it done. So having said all of that, I guess it's time to have a discussion, debate.
So I'll start. First of all, this is very hard. And one of the things that he's constrained by is, we have so many different competing entities making recommendations now, different lobbying groups and stuff. And overall, we still have FDA, I guess they're not recommendations, but FDA stuff that they've done for TPA and endovascular care and stuff like that. And right now, there's some dissonance because different groups recommend different things. But that doesn't bother me. Does it bother you? No, not at all. So if the FDA recommends TPA out to 3 hours, but the American Heart Association recommends it to 4.5 hours, what's your response to that?
I think that's a clinical judgment that's made by a particular institute. That would be a clinical decision made by the institute and the physicians that are involved. But on a larger scale, the thing that's really changed is not whether we're talking about 3 hours, 3.5 hours, 4 hours, 6 hours. All of these numbers over time keep being extended. But the one that's the big change is the 8 hours for the large vessel occlusion and endovascular or invasive or minimally invasive clot removal using whatever device you want to use. So that one was a big one.
So the FDA recommends for many of these devices up to 8 hours, but then there are groups that suggest only to 6 hours or 6.5 hours. Some people, and we certainly do this, if you have a brainstem basilar artery occlusion, there's no limit to time. So do you have discussion on that or thoughts on that?
I don't know that those particular studies had recommendations for each of those various subcategories. I think it was primarily the large vessel occlusion issue that was studied, and I know that there's data that's out there and people are looking at everything, but these were like 3 or 4 totally independent studies that all came up with the same thing, and that's going to be pretty hard to go against at this point. So, well, maybe that's not the right way to say it, but they have the data and the information and the research to support what they're saying. So, again, I think it's something that is a general enough recommendation that we can make that's applicable to the state, all the RAC regions, and it's not it's not overly burdensome or impossible for the different areas to do.
Or if I can put words in your mouth, it's not exclusive.
It's not exclusive.
Well, it's going to be interesting. Endovascular success is 3 times higher than IV TPA. And now there are people that are even looking at possibly doing trials of endovascular versus TPA, not doing the TPA, whereas everything that we've set up is really drip and ship, a combination therapy. So, I mean, it'll be real interesting to see where it goes.
But all of those things that are in place now, you don't have to take all of those away. What needs to be added is in that selected category of large vessel occlusions, though, you may start TPA and do all of those things. They had all of those in the studies, but at the end of the day, what was the change was doing an endovascular procedure to remove the clot, and that being extended out to 8 hours. And so, again, that whether we drip and ship, you start and treat and stay, that's, again, a regional, I think, decision in what works with the politics of the particular area. But the big ticket item to stay current with what are national and international standards, I think we have to have this type of language in there. And then I don't think it locks anybody into anything that can't evolve over time and change as the data comes in.
And one of the things I hope your committee will help and continue to do, how do we best identify people with large vessel occlusive disease? I mean, Can we only do that with CTA, MRA? Can we do that with a clinical exam? We were talking earlier about the rules of 8. What's your thought on that, or where are you going on that?
I mean, we're going to have to defer to our radiology brothers in the sense of, you know, whether it's MRI, CTA, you know.
Or like a clinical exam, or like one of the different clinical field tests.
I think you can raise the level of suspicion to the point of being appropriate to do the appropriate test, but no one's going to treat these without all of the appropriate tests being done. And so, again, whether you go to a primary or even a support, you know, stroke center, you start the process there, but ultimately you're looking for these candidates to be able to treat. So which EMS exam system you want to use, you know, we can go through that again and debate that on which is better, which is more feasible. But at the end of the day, the main thing that's the change is treating these infarct areas.
I think we're going to have lots of discussion on what the best field test is going to be ultimately. And I think, Paul, haven't you guys been working on that in your group, and you put some paper, do a paper recently?
Yeah, we've discussed that a little bit, and we talked about it last time that, you know, there are 4, and then there was a guy from Houston that raised a 5th scale that are commonly used in the emergent setting field studies to kind of point towards a patient that may potentially have a large vessel occlusion. I think the take home from that previous discussion was that basically all of them are pretty similar in their ability to identify a large vessel occlusion. There's something like 60 to 80% sensitive and specific, which is not perfect, but if it gets, you know, X number of patients with large vessel occlusion to the appropriate center faster, knowing what we know about the benefits of thrombectomy, the faster they get that clot removed, the better. As far as research into IVTPA versus thrombectomy, I think the only time that we're ever going to get there is when somebody presents directly to a comprehensive site that has a waiting interventionalist on call right there ready to go. Otherwise, I think in all cases, giving TPA and getting them over to another site is going to be the best route for the patient. But I think as we talk about all these transport paradigms and trying to come up with the best way of treating the patients, it's complex. It's going to be tough to get one rule that fits to everybody, but I think we can probably come up with some basic rules that help at least guide the racks. Given the expanse of some of the larger racks, especially in the northwestern part of the state, I mean, some of these are huge and don't have a lot of large medical centers. Their rules are going to have to be different than, you know, in the middle of Austin, the middle of Dallas, the middle of Houston, where you can throw a rock and hit 3 comprehensive centers.
And I mean, everything that was just said, I agree with. But at the end of the day, whether you use the Houston system or whatever triage system you want to use, and you get to 60, 80%, you know, identifying these patients, the point is that we now have something that we can offer them out to a period of time. So there's not the time constraint in the sense of we've got to get this right the first time. And if we don't get them shipped and taken to the right place, that's a problem. So in a sense, to take them to a primary, to take them wherever, once the diagnosis is made, the clock's ticking, and you've got to get them to a comprehensive center for them to be treated. And there darn sure ought to be 24/7 interventionalists available in a comprehensive. So, you know, that's one of the requirements. So. I mean, that's straight up. So once it's identified and what different regions decide to use in their triage or for their EMS people, I think that's, you know, for what works best for that particular area.
Well, one of the things I thought was most interesting at the council level is in the data collection, trying to come up with criteria that really measures the pulse of the system and not necessarily individual endovascularists and things like that. the number that was used is picture to puncture. So from CT scan to puncture, because there might be varying times on how long it takes to do the endovascular case. But as a measure of the system, when the CT is done, or MRI, to the puncture time, that's a measure of the system, and that's where that number came from. And there's lots, and there were many other numbers that were looked at for that to try to decide on that. But, and maybe Dr. Morton will change that on the next year go around, but that was what she gets to start with. Other thoughts, because you did, I mean, there's a tremendous amount of work, and this is a brilliant white paper that you have out there, and I think it's on the website and as for a resource for people to use. Other thoughts, comments?
I don't know how brilliant it is,
Oh,
but it's pretty simplistic. Straightforward.
Taking a complex subject and making it, reducing it is a monumental task. So thank you. Okay, so next up, I'm going to sort of jump over this one topic and then come back to it, the number 5. We've had requests from ASRH, DNV, CIHQ. They've all requested to become certified agencies for level 3 support stroke facilities in the state. As a reminder, this committee and GTAC voted that as a criteria to approve these certified agencies, we were going to use the Brain Attack Coalition's work for support stroke facilities. And so I'm going to give all this to Dr. Morton and her work group to see if these different agencies meet that. And there were also, from the State Stroke Act, when we first started doing this, there were also some things that were a part of that, also basically defining what a support stroke facility is for our state. That I'm giving to her to look at as well. We were and are the first state to have 3 levels of stroke center certification. We did it before anybody else, and our support stroke facility designation predates the stroke-ready hospitals and was, I think, a motivator to help that come to be. So Texas sort of led the pack on this, and now there are a lot of people that want to join in. Last up on the agenda is to review and discuss the revisions to the Texas Administrative Code. The part that deals with stroke is 157.133. I don't know how many people have looked at that. Basically, the current revision hasn't taken in the Brain Attack Coalition stuff for support stroke facilities that we voted on yet. Most of it's pretty static and unchanged. I don't know if anybody's seen that. One thought I had is that we can send it to everybody for additional comments. We sent in, back when we reviewed this, it's been 2 years ago, we sent in about 10 changes. I don't know if they were incorporated or not. But we went through a process where we reviewed this at this committee level and then took it to the general counsel, and then there were these forms that went in. Did you guys get those? Mm-hmm. Do you still have those? Can you send me a copy? One of the things that I saw in here that I wanted to ask about is one of the possible revisions was let's see, page draft 10, line 49. It says capability to have computerized tomography images interpreted per current stroke standards of care. And then it said it was originally within 45 minutes of patient arrival, but that was crossed out. Do people have thoughts about that? Current stroke standards of care versus within 45 minutes? Is that something anybody's worried about?
I know we strive for half an hour, we strive for 30 minutes in all the facilities where we work. Whether or not that's feasible everywhere, I couldn't tell you.
Well, I wanted to, because this is complex, and I think everyone, I mean, the idea is to get everyone's comment and input on this. I wanted to open this up. First, everyone on the dais, you may or may not have had a chance to read this. You probably haven't. I could have had a little difficulty finding it. I'll send it out to everyone. But some of the people in the audience may have had more chance to look at it. Is there anyone in the audience that has comments or changes that they would like to have entertained in the new TAC? And there's a rush to the microphone. Okay, so hearing none, we'll publish this in, I mean, we want as much input as possible, right? Correct.
Dr. Rutledge, just as a reminder, we had the November meeting at the
Right.
last GTAC in which we had a lot of great feedback and great comments. Unfortunately, due to the neonatal rules, I have not had a chance to go back and do any revisions on that. So if you did provide comments at that meeting, we have not done a revision since then, just so everyone is aware. Yes. And yes, it is on the website under the rules portion, and it is the same one that we received comments for at the November meeting that we had at GTAC.
I just had a quick question about that November meeting. I know that there's a lot of comments, and I think the resolution was to have another meeting to sort out the comments. Did I misunderstand? Okay. Do we have a tentative date for when that might be?
No, we don't.
Okay.
Because of the neonatal rules and getting the adoption packet ready to go, stroke and trauma have been kind of set back. But hopefully we want to get started with that in the next few weeks, so we should be having a meeting date coming up.
So it was a little rude and I went past you. Do you have any comments or things that you would want to bring up from a DSHS point of view? No. Okay. Are there any other things from the dais that you guys want to discuss at this time? None. Are there any general public comments? We're open to anything. Great. Please tell us who you are.
Hi, I'm Gabby Teal. I'm with the Office of Acquired Brain Injury, and we just wanted to let you know that we have a free brain injury training. We can do it for first responders, nurses, social workers, really anybody. We tailor the training to fit the interest of whoever the audience is. Generally what the training covers, what is a brain injury, how does a brain injury occur, what does a brain injury, do to a person, what are the effects, and then we can go more specifically into prevention if that is what they're interested in, or how to best communicate. And so this training is free, which is always good, and we can either travel to you and do it in person, or we also have the ability to do it as a webinar. So I have some flyers. I stuck them by the registration table. I also have some here, and you can grab some from me if you are interested. Again, it's the Office of Acquired Brain Injury, and I'm Gabby Teal, and you can get a free training.
Thank you. That's great.
Hi, my name is Linda Jones, and I'm also with the Office of Acquired Brain Injury, and I wanted to let you know, first of all, if you haven't had a chance to go to our website, really, you should go there. You just have to Google Office of Acquired Brain Injury, and ours is one of the first or second places that will come up. And we've got a really cool set of short videos that describe what it's like to navigate the brain maze. As you all are well aware, having a brain injury is one thing, and afterwards is a whole nother thing. So the videos are really helpful in letting people know what to expect and how to go about rehabilitation and all that goes with it and living in the community. In addition to that, I wanted to let you know that we are going to be having we've formed a Northeast Texas Brain Injury Coalition with a number of agencies and whatever in the Northeast Texas region, including University of Texas System, ETMC, we've got the Center for Rural Community Health. RACG has been very helpful, very instrumental, in fact, in helping us get the summit together. We're going to be talking again about what is a brain injury, what's the data look like for the Northeast Texas region of the state with respect to brain injury, what can be done immediately and for the long term. And we hope to get people interested in the provision of services and long-term supports for people in the community. So we're very excited about that and hope to be able to extend that into a movement that spreads throughout Texas so that people will be more aware of what a brain injury is and how it can affect people and the need to provide supports in the community, because that's the rehabilitation and recovery, that's one thing, but the long-term care and support is really important and really helpful if people can understand what it's like to have a brain injury, because you can't see it and a lot of times people just don't understand. So we have some cards again on the registration table about the summit, and we hope that any of you who are in the area will attend, and if you can't, you'll let your colleagues know and hopefully they can attend. So thank you.
Thank you. Any other comments?
How you doing? Jeff Thibodeau with the Acadian Ambulance. HT, specifically for you, you said there was a link for education, stroke education for EMS. Did I understand that correctly? For the continuing education for EMS?
Not specifically. It's just listed on the CE requirements. Okay. As far as the link goes, as far as the content of it, DSHS approves all the CE content. It's put the companies that like CenterLearn or whoever you use have to meet the requirements. DSHS then gives them a number and they can produce that to be available.
Okay.
We're working on trying to get a set of places you can go and where to go, how to get it, whether it's free or who you contact, that kind of stuff. So it's just easy to go to one site and do that. We haven't done that yet. We're working on that.
Okay, good. As
Yeah.
also the RAC chair, it'd be good that, once we find this out, it can be sent to the RAC chair so
Yes.
we can spread it out amongst the group.
Yes, absolutely. And our thoughts are to the medical directors, also the RACs, EMS services, everybody that's going to have access to it, that needs access to it. We're going to try to get the word out.
Thank you.
Any other public comments? And again, I want to remind you that the Texas Council of Cardiovascular Disease and Stroke will be meeting Friday at 1 o'clock right here to coordinate with the different RACs. If anybody's here from RAC H, if they'd meet me after the meeting, I'd like to talk with them if possible. Other than that, I'll call for adjournment. All agree? Thank you very much. That's the end. That's the Stroke Act.